this funding we're getting to build up more medically assisted treatment facilities.
Thank you very much. We have two more questions. Dr. John Rosa of Darnestown, Maryland.
Are we on? There we go. Thank you. First, I want to thank the President, First Lady, administration, panel, participants. We have a lot of experts and families that have been affected, so thank you very much for being able to put something like this together. My name is Dr. John Rosa. I have 14 integrative medicine clinics in the DMV, which incorporate medicine, chiropractic, physical therapy, acupuncture, yoga therapy, mindfulness, nutrition, supplement treatment for pain. Many of the government agencies and some organizations like the CDC, FDA, the VA, American College of Physicians, Joint Commissions have suggested and/or required physicians to use these alternative treatments as the first line of care in lieu of medication. 90% of the consumption of opioids comes from this country, and we're 5% of the world's population. So the other parts of the world have obviously been using these type of alternative therapies to combat pain before that prescription's written. And that's just to let it sink in. Over 90% of the opioids produced are consumed by the United States of America. And I also treat professional athletes. So if we get an NBA player who gets hurt, hurts his back, we have 4 or 5 experts on this guy immediately. There's a chiropractor, there's a therapist, there's an orthopedic surgeon, there's the trainer. He's treated 3 times a day until he's okay to practice. When he practices, we videotape what he's doing so we know that his motion's okay. He gets to be cleared to play ball when he is in pre-injury status. Same guy gets hurt, same exact condition, goes to the medical office, gets an opioid, gets sent home for rest. Where does the breakdown occur? We know that these research methods of treating people and that are scientifically proven and used in professional sports not good enough for the average person. We're creating a society of chronic pain patients because when they go home with that first script and they're not treated right away, the propensity for this to be a reoccurring condition in the future goes higher every time that episode occurs. So going way upstream in prevention is to stop that script from ever getting written. We've touched on it a bit. But part of I have one of my clinics out of the 14 is a free clinic in Maryland. And in that free clinic, it's in a very busy medical practice, primary care, and within a year's time, we've reduced the script writing by 70% for opioids in that clinic. Now, I went and we had our meeting, and I said, you got to tell me what happened. 70%, 10% you write a paper, 70% you call somebody. Yeah, and the answer was, well, you're here. Can it be that easy that if it's available, you're not going to have that process take place? So my question, with all that emotion, because I obviously head into this, but the question would be, how do we instill the proper referral for and the insurance reimbursement of these known evidence-based alternatives for treatment? And I am at your disposal at any time because I've been doing it for so long, so feel free to call on me when needed.
Well, Doctor, that's exactly the issue I was mentioning to Cece a second ago, which is the investment that we're making at the National Institutes of Health around alternative pain management to build the evidence base to support reimbursement. We also, it's a fair point, we need to look at our reimbursement systems, which were really built in the 1960s around siloed ways of paying for a drug, paying for a device, paying for a procedure, and set in statute in a very concrete way that isn't always as adapted and adaptable to evolutions in non-traditional forms of treatment. So in fairness, we need to look at that, and we need to do so from an evidence base, working with our National Institute of Health and the Food and Drug Administration. So we've got that charge, and that is part of our focus.
Yeah, I think about what you're trying to do with 4 different approaches, and Secretary Azar just mentioned 2 of them. You have to have the providers in your network, if you have an insurance plan that has access to them. You have to be able to pay the providers for those types of alternative or integrative therapies. But there's 2 other things that we've learned in the Department of Veteran Affairs. One is we encourage team-based approaches to care, and I think that's what you're doing in your clinics. Instead of it being a solo provider, we have teams of nurses, doctors, physical therapists, pharmacists, social workers, all of whom then can suggest alternative approaches. And finally, what we're doubling down on in the Department of Veteran Affairs now is teaching the patient, in our case the veteran, self-care, and letting them know how do they take care of themselves and what alternatives should they be thinking about rather than just listening to what a provider says to them so that they're an active participant. So I think when you take those four things, we can see more of what you've been able to experience.